Schizophrenia remains one of the most severe disorders we have in psychiatry and in medicine, and one of the pressing needs is to improve the outcomes. We can do that with psychosocial interventions, but also with pharmacologic interventions. And for the past 7 decades, we've had only one mechanism of action, and that is postsynaptic dopamine blockade. But we believe that the illness actually has other mechanisms, presynaptic dopamine, that is oversynthesized and released, glutamate, maybe also serotonin and other receptors. So we need new treatments in order to improve outcomes. What outcomes? What are the needs? Well, 40% of patients have treatment resistance. Another 40% might only have partial response in terms of positive symptoms. 40 to 60% of patients have negative symptoms that really impair functioning. And about 80% or more have cognitive dysfunction. And we have nothing approved for either cognitive dysfunction or negative symptoms. Recovery rates overall are 13.5%. In first episode patients, 20%. What's recovery? That's symptomatic remission for at least 6 months or longer and some functional outcome. So we need to do better. We also need treatments that don't have some of the postsynaptic dopamine blockade-related side effects. EPS, prolactin elevation, sedation, weight gain, metabolic abnormalities that are very common with our current medications, although we have been able to refine them. So there are multiple issues on the table that need to improve, including also rational polypharmacy to improve outcomes. So we hope that drugs with a novel mechanism of action can be part of the answer. The fact that we only have dopamine blocking agents right now is not for lack of trying. Many other avenues into the brain have been tried for psychosis. Currently, we have a couple of front runners, and we hope that at least 1, 2, or maybe even 3 will become available. Which are these? Well, I think the first one that we need to mention is muscarinic agonism. That indirectly reduces the input of acetylcholine from the hindbrain and the midbrain and into the striatum, reducing presynaptic dopamine. Interneuronally, reducing the output of dopamine. And then also, that's via M4, muscarinic 4 autoreceptors. But there are also agents that have, in addition, M1 downward reduction of dopamine tone via stimulation of GABA, which reduces glutamate input into the striatum. So muscarinic agonists might be helpful, and the M1 contribution can also help cognition. Then we have TAAR1 agonists, trace amine-associated receptors that are cool. They are intracellular. These trace amines are not released from the synaptics into the synaptics cleft. They're actually intracellular. And there's modulation of pre- and postsynaptic dopamine receptors, of presynaptic dopamine tone, serotonin, and glutamate. Then we have serotonin modulation. 5-HT2A inverse agonism or blockade may improve output of glutamate and dopamine in the frontal lobe and reduce negative symptoms. And then we also have other agents that will work on the glutamatergic system. For example, glycine transporter 1 inhibition, which increases glycine, the co-agonist on the NMDA and also AMPA receptors, improving cognition. But when these medications become available that don't touch the postsynaptic receptor, that don't have the side effects we know, they may have others, what should clinicians do? Well, know about this because we have to expand our knowledge, how the brain functions, how these drugs function, how they interact with the illness, but also with expectations that patients or we have, and interact with the currently available dopamine blockers. So we need much more information and experience in order to hopefully find patients that particularly respond to the new treatments, but also identify those that might not be helped by either of them and may still be candidates for clozapine, so that we can individualize, personalize outcomes and treatment for our patients.